So I am Danielle Loeb. I'm a provider here at Anschutz. I think I know everyone. Um, and I am being joined today by a crew of folks, which I am very grateful for. So Alondra is here.
Hi, my name is Alondra Cuellar, and I'm a medical assistant at internal medicine, and I work closely with this group of patients.
And then Lauren Barr from, the rest of the folks are connected with the UC Health Transgender integrated
some helpful references
multidisciplinary.
that you could use if you wanted to, because there are a ton. Like I can see some times where
Some
PMA
folks talking. Could you mute
helpful,
yourself?
but in that specific.
Thank you. So Lauren, you want to say hi?
Sorry, I'm in a shared office right now, so bear with me. I'm Lauren Barr. I'm the social worker for the Integrated Transgender Clinic and the Endocrinology Clinic.
And Kylie Fisher.
Hi, everyone. My name is Kylie Fisher. I'm the program coordinator for the Integrated Transgender Clinic.
And Benny. Did we lose Benny? I know Benny might be traveling. Oh, there you are.
Hey, sorry, it just kicked me out. Sorry.
Benny is a therapist with the Integrated Transgender Program. All right, so today we're going to talk a little bit about basically cultural competency, or how do we provide as a clinic, as a whole, how do we provide affirming care for our transgender and gender diverse patients? So if I can figure out my computer. So today I'm going to do a little bit in the beginning on overview, what is gender identity, what are some of the terms, and then a little bit of background on healthcare disparities, what patients might be coming to us with, why it's important to get this right, I would say. And then I'm barely going to touch on gender affirming hormone therapy, just to give you a taste of what the hormones are doing, what kind of hormones we're using. And then I'll turn it over to Lauren Barr, who will give us a bit of a tutorial on how to provide culturally competent care. And then Alondra is going to talk a little bit about SOGI, not deep, in-depth workflows. We'll do that later. But just to give an overview of how to document pronouns, etc. And then Kylie's going to talk to us about the Integrated Transgender Program and how we can access it for our patients. And then we'll all do a Q&A. So caveats. Just know that this is an overview, general concepts. We still need to work with Diana to roll out workflows for things like documenting SOGI. Okay, so that will happen. Don't worry. So, what is gender identity? So this is your friendly gender unicorn, and it just is a little bit of a look at what is gender versus gender expression versus sex assigned at birth, etc. So gender identity is different from what a doctor said you were when you were born. And it may or may not align with how you look, okay? It's purely how a person identifies. And that is, every person gets to say that for themselves. And again, it doesn't necessarily matter what somebody said they were at birth or how they look, okay? Gender expression tends to run, that's when it's feminine, masculine, maybe something else in how somebody presents themselves. So what clothes they wear, etc. Sex assigned at birth, maybe based on chromosomes, probably based on genitalia at birth. So female, male, intersex. Who you're attracted to, so usually called sexual orientation, completely different. So, and then this is kind of important and something that actually Kyra has brought up, people have brought up. Like we often ask, are you attracted to men, women, or both? And just know that that needs to be a little more nuanced now. So, but who you're attracted to is sexual orientation. And then emotionally attracted to is also even can be a separate category. So what is sex versus gender? A little bit about like what you're assigned at birth and how you identify. So the pink baby and the blue baby. So assigned at birth male, they were given the blue ribbon, or female. And then what that can look like is that person can identify as a male, and then you would call them a cisgender male. Or they can identify as a female, and you might call them, they might identify as a transgender female, or trans feminine, or trans woman, or just woman. And so again, as a somebody given pink at birth, they may identify as cisgender female, or transgender male, trans masculine, trans man, or non-binary. And under non-binary is sort of a bigger umbrella of agender, gender queer, gender fluid. Somebody could be assigned either male or female at birth and identifies non-binary. So again, know that some of this terminology changes a lot, okay? But this is fairly current. Gender identity, again, it's self-identified gender. How I identify myself. It's not necessarily visible to other people. Sex assigned at birth is, again, usually based on external genitalia, what somebody put on your birth certificate. Gender affirming, so, well, I'll leave it to Lauren to say how you're going to talk about these things when you talk to people later. Gender affirming hormone therapy we'll talk about. I use the term a lot. Just know that these are the medicines, basically, hormone therapies we're giving to affirm gender, and gender affirming surgeries, procedures people have. And then just a little bit of a caveat. This is from a study we're going to be looking at a little bit in the next couple of minutes, but it's a huge study, the 2015 U.S. Transgender Survey of 27,000 respondents in the U.S. And if you just look, the basic point of this is not everybody likes the term transgender, okay? It's why I tend to use trans with an asterisk, or transgender and gender diverse. So it's always good to just to ask people how they refer to themselves, what language they like, okay? And then these slides are stolen from our very own Dr. Rita Lee. And just a little bit to give you some sense of what patients are coming to us from, and why we're taking some special time and energy on making sure to get language, use language that is welcoming to these patients. So this, I'll look at this and that other study I just mentioned. So this is from Transparent, the State of Transgender Health in Colorado. This is a survey of 417 transgender, gender nonconforming patients in Colorado. So this first slide just looks at general disability. So if you just look at transgender patients versus all Colorado, if you don't mind just muting if you're not talking. number of days not in good health, you can see they're about double for transgender patients. Number of days mental health was not good, like triple or almost quadruple non-transgender patients. Number of days they kept you from usual activities, almost double. So general poor health, or especially when compared to non-transgender patients. This is in that US study, the large survey study. And you can see here, this is again just general disability status, difficulty concentrating, remembering, making decisions because a physical, mental, or emotional condition. Look at this, 30% versus 5%. So it's causing, there's something, and we'll look at what, causing a certain amount of distress, right? And difficulty doing errands, like some functional challenges. And then any disability, up to 39%. So pretty high burden of disability, especially compared with non-transgender patients. This is the Colorado study, looking at mental health conditions. So current depression, 44% in transgender patients versus 7% in the non-transgender patients. Contemplated suicide, 36 versus 4%. Ever told you had anxiety disorder, 53 versus 13. So these numbers are not, they're extraordinarily high. And I'm giving you this to know, just to have a sense of when patients may seem slightly reactive or, quote unquote sensitive, know what they're walking in the door with a little bit. Again, this is the larger U.S. study with sort of similar comparison rates of very high rates of distress, psychological distress. So why is this happening? Why? So we're just going to look at a couple of what we might call social determinants of health and just some background. So this is from the larger U.S. survey. So this is immediate family members stopped speaking or ended relationship when they came out. So across race, across culture, these are very high. An immediate family member broke off contact. Experiences of people who were out as transgender in K through 12, so younger, where percent of those, so these are folks who were out as trans in before K through 12. Look at these rates. Verbal harassment, 50%. Not allowed to dress in a way that fit their gender identity, 50%. Discipline for fighting back against bullies, that gets a little lower. Physically attacked, almost 25%. So you can see one or more experiences listed, 77%. So this is sort of generally bullying, I would say. And then 1 in 10 respondents that a family member was violent to them when they came out, or when it became clear, and nearly 1/3 had some kind of harassment if they had like an ID that didn't match with their presentation. And these are rates of assault. So verbal assault, physical attack, intimate partner violence, very high, sexual assault. So people aren't living easy lives generally, and so it makes it even more important that we're welcoming. And so how welcoming are we? Access to care. So this is LGBT respondents in general, but if you can see, I refuse needed health care. Some LGB, lesbian, gay, and bisexual, more transgender patients, and then also HIV. So some folks aren't getting care they need, or they're reporting harsh or abusive language from healthcare providers. This is about safe healthcare. So 33% reported having at least one negative experience related to being transgender in healthcare settings. And people of color, people with disabilities, those rates are going to go up. 23% did not see a doctor because of fear of being mistreated. 33% because they couldn't afford it. So people are having trouble accessing safe healthcare. And then I like this slide because I just think it underlines, it's in a patient's words, and I like that. So it's from a study where they got some qualitative, some people told their story in a qualitative way. So this participant, a 26-year-old Black trans patient, encountered a provider who was insensitive about trans patients and talked to them about it. And they said, I actually spoke to her afterwards. You're going to have more clients like me. What are you going to do for best practices? These are unacceptable standards of care. And she explained to me, well, this is the first time something like this has happened. I'm like, granted, but you need to prepare yourself for different types of people walking into your office. So that's what we're doing here. We are preparing you for different types of people walking into your office. And just a touch on hormone therapy for the docs on here. Everybody's going to end up doing cross cover for the providers on here, cross cover for other providers. And I am providing a set of resources for you on that. There's a talk on Thursday of this week about hormones in particular. I'd love it if everybody would attend that or watch that. If not, we do have cheat sheets, just so you know, that are coming out for you for cross cover and that kind of thing. So this is not an attempt to cover that. So why are we doing gender affirming treatment? We talked a little bit about the distress, the psychological distress. And so this study, it's a small study. There's some other studies, but it just gives a nice view. So this study just looked at patients who had, some of the patients in this study had, 17 of them, had a psychiatric comorbidity, and they were looking for reductions in anxiety or depression symptoms. And in 2 years, so they followed up from patients on gender affirming therapy, and they found even in this small sample of patients, it's a really small sample, so it's hard to find statistical significance, significantly lower subjective levels of gender dysphoria, body uneasiness, depressive symptoms, as compared to those without, those that were on affirming therapy. And then those that actually had body modifications, so they could see objective physical effects from their therapy, even better psychological outcomes. And there's more studies like this, but basically it makes a difference. Like just affirming gender, just providing hormones, even without any changes, starts to make a difference in some of this. So this is your 2 seconds on hormones. So transmasculine, and this is language that is usually pretty safe. Transmasculine and transfeminine versus, again, sorry, I'll shut up. Lauren will talk about that. So testosterone, it's your main medicine you're using, main hormone. And they may be getting testosterone via IM, intramuscular injections, or subcutaneous. They also may be getting it through gel or a patch. So just to give you some sense of that. What it's doing to them is facial hair growth. So testosterone will cause facial hair growth. It actually will make the voice deeper, which is, those are fairly permanent effects of testosterone. Changes in pubic hair, some changes, chest hair, so the hair changes, things like that tend to be permanent. And then changes in body mass, changes in like this muscle mass, fat redistribution, cessation of menses, all that is temporary. So if they're on it, they'll get it. And once they go off their hormones, it'll go away. Again, in the hormone talk, I'll talk a lot more about that. And then, for cross cover, as you all get and just seeing each other's patients, I will cover some of this. I'll give you some handouts on this so you're aware. But again, it'd be great if you could attend that talk. We're generally monitoring hemoglobin hematocrit because testosterone raises that, testosterone levels, lipids, weight, blood pressure. Actually, guidelines are fairly consistent with any person in primary care, and then osteoporosis if they've stopped testosterone. And just don't forget that for all, they call transgender patients will say, oh yeah, broken arm syndrome. And what they mean by that is that they come in with a broken arm and you treat their transgenderness in some way. So remember that they're whole human beings. And so they're still going to need a PAP if they have a uterus and a cervix, you know. They're still going to need contraception counseling if they're just on testosterone. They're still going to need, you know, their whole person. So you're still doing primary care for their whole person. And then estrogen and anti-androgen treatments. So for trans feminine patients, you're giving some form, they're usually getting some form of estrogen that is not ethinyl estradiol, hopefully, and which could be intramuscular or transdermal, a patch, or a pill. Sorry, this one's a pill. And then they're getting anti-androgens. Usually just spironolactone is what we're prescribing. We don't have this, it's only in Europe, and then GnRH agonists generally refer to endocrine for that. And those effects are, just so you're aware of the general effects, unfortunately the voice effects, estrogen doesn't cause that. So you're not going to get the voice effects that testosterone gives, you know, you don't get a parallel. And they might get a little less hair growth, but it's not as dramatic. They're going to need to do something for hair. And so the big changes are redistribution of body fat, breast growth, softening of the skin is usually actually the very first thing. And then oftentimes decreased sperm production, maybe decreased testicular volume. They may get some erectile dysfunction. Don't assume that they don't use, that they don't want their, to be able to have sex with their penis. So just know that these are, if you're seeing patients, these are some general changes you can expect. And the general monitoring is testosterone levels, estrogen levels, electrolytes if they're on spironolactone, and osteoporosis age 60 or if not taking hormone therapy. And again, I will go over this in much more depth on Thursday for providers and nurses. All right. I think I kept almost to my time. I went a little over. So turning it over to the fabulous Lauren Barr to educate us on language.
Okay, don't talk me up too much. So let's see, I'm gonna get my stuff together here. So one of the things that I wanted to talk to you about first is just some of the different definitions to kind of help folks understand. So these are the different like colors or flags that are associated with different identities. So I wanted to go with that. And so obviously, someone who identifies as transgender refers to someone who does not identify with the gender that they were assigned to at birth. And again, these can be fluid, so keep that in mind. Non-binary often refers to someone who does not identify as exclusively male or exclusively female. Gender fluid refers to someone whose gender identity changes over time from one end of the spectrum to the other. Gender queer can often be referring to someone whose gender identity falls on the spectrum between male and female. And also, of course, cisgender is someone who identifies with the gender that they were assigned at birth. Okay, so I'm not going to go through all of these, but just keeping in mind a lot of the pronouns that we use. They're not the only pronouns. There's obviously folks can use any amount. New pronouns emerge in our language all the time. So it's really good to just ask someone. So one of the things that I like to do in both the, medical and my job situations and also social situations is just make sure that if I'm meeting someone new, I will say like, oh, my name's Lauren, and I use she, her, hers pronouns. And so that's just a really good way to introduce myself. And it doesn't mean that the person that I'm speaking to needs to identify as transgender. It just means that that's a good way to introduce yourself to anybody. Okay, so I think one of the most important things for staff to have is just a lot of examples. And so what I like to do is just be really direct and have a lot of concrete resources. And one of the things that I've noticed with a lot of my own practice and when a lot of MAs or new providers have questions is folks get really nervous and they don't want to make mistakes, obviously, and don't want to unintentionally hurt someone or frustrate someone. So I always say that it's okay to definitely repeatedly ask someone's preferred name and then their pronouns. And even though preferred pronouns or preferred name isn't the best thing to use or the best phrase, because if you think about it, my preferred name isn't Lauren, my name is Lauren. And so that's the same thing for trans or non-binary folks. So especially in a medical setting, a lot of questions are inappropriate or they're only needed to be asked for certain situations. So when necessary only, you can ask someone's gender identity, their name assigned at birth, or their legal name. Or you can say, may I have your legal name to access your records? And one of the things that's really, really important to ask, especially for our trans folks, is giving them the reason why you're asking all of these super intimate details. So ask if you need to know their legal name, say if you're taking labs or if you're looking through old records, say why you're asking those questions. Okay, so on the far right there, it looks like we have a similar picture from the unicorn, but I do like the little genderbread person. Let's see. So I don't know situations for me, I don't ever ask this question, but sometimes for our surgeon, I know that he may ask like the different partners that folks prefer, the different kinds of sex that they're having. So what's your sexual orientation? Things that you should absolutely never ask if somebody is transgendered. So if you can look at the ED is not appropriate, or what are you, or questions like that that are really putting somebody down or othering them.
And we will talk a little bit, especially as we roll out. So how we can ask about sexual orientation, or more particularly like who you're having sex with.
Mm-hmm.
So we will address that over time.
Hey, Danielle, can I ask a question?
Yes.
This is Amber. I was just curious, are our MAs and MA Academy being told to ask about sexual orientation?
So we're going to address that. There's currently an issue actually, because they're currently trained to ask, are you having sex with men, women, or both? I think, and
Yeah.
I think that's a problem because it doesn't.
So you're working on it. Okay.
Yes, those are the only two questions that we are asked to ask the patients, whether they're having sex with a female or a male, and those are the only options that we have at the moment.
So
yeah, it just didn't seem like, it seemed like the slide is, it seems like the slide is saying something different than what we're actually doing in our practice. So I just want to make sure we're reconciling that.
We're working on it.
Okay, awesome.
It is a known problem, and yes. Yeah.
Okay. And I won't go through all of these because I can see them on the slide, but these are all just some terms to avoid and just terms that are outdated and very hurtful to people. Okay, so these are a lot of things that I definitely use, especially when I first started this job, because we always want to have examples and ways to make things easier on ourselves, which then has a better experience for our patients. So starting with yourself, which is something that I already gave the example about. Again, it can be with and should be with anyone, not just with patients. So starting with your name, your title. So I'm Lauren, I'm the social worker, and I use she, her pronouns. One of the things that's really good that you can do is wear a pronoun pin on your lanyard too, or on your clothes. And let's see, what else did I have there? Wear a rainbow lanyard, a trans affirming pin. And one of the biggest things to do that can be helpful is to ask for more education if you need it. I'm always available by email or Teams and all of that, because even though sometimes I know for myself starting out, it was really intimidating and I felt ashamed that I didn't know very much. And instead of kind of sitting in that discomfort, I tried to make sure that I was outreaching for more education, because that's one of the best things that you can do. Okay, so just some tips and tricks again, things that you can ask over and over again if you don't know someone's name, if you don't know someone's pronouns, even if you forget. I know that when I meet someone new, I have the common bad habit of immediately forgetting their name. So it's okay to ask again. If you don't know why someone is at the clinic, another helpful thing is that if someone needs help, if they seem panicked or withdrawn, if someone needs help, if they seem upset. As Danielle talked a little bit about, but just to reiterate that the healthcare system, whether it's physical health or mental health, is one of the most traumatizing places for trans folks to be in. And so just parking and getting into the lobby can be traumatizing. So just keeping that in mind. And one of the biggest trauma-informed care practices you can do is to make sure that if you're going to touch someone, whether if it's just on the shoulder to say hello that you're entering the room, especially for OBGYNs or any kind of doctor, is to say, I'm going to go ahead and touch your leg now because of this reason. Is it okay if I shake your hand? Things like that. Always make sure you're going to tell someone before. Okay, avoiding using gender identifying language when if possible. This takes practice. So one of the things that I had to really work on is instead of saying, the common word guys, so like hi guys and things like that. A lot of people will use the word folks. That's what I use now. A lot of people use the word y'all, but that's not comfortable for me, so I don't use that one. And just trying to treat, this group of patients like anybody else. So any other patient that would be coming in. So don't interrogate them, ask and believe them, make adjustments in your own behavior. I think one of the biggest things is asking yourself, is my question necessary for this patient's care, or am I asking them out of my own curiosity? If it's just your own curiosity, then don't be asking the question. Yeah, stay relaxed and making eye contact. This is a patient like any other patient. And then, let me get that thing up. Okay. So you can see the bottom, continue to use the preferred name or their name and pronouns even when patient is not present. That can help you to really remember. Hold yourself and each other accountable, politely correct misuse, and do not gossip or treat as sensational. And so I just saw real quick, let me pull this up in the chat. So I know that we've had some work to try to get these pronoun pins in bulk from UC Health. I don't think that that's happened yet, but you can get them off Amazon and probably places, like Etsy, or the best would be to purchase them from trans or queer artists. But I also I can put my email in the chat, and I always have them on hand, and I'm happy to distribute those.
There's also some pronoun pins in the resident room, FYI.
Oh, okay, good. And if you mess up, it's okay. Just apologize, correct your statement, and move on. And that's the best way to kind of go through that. You don't have to harp on it and keep going and keep apologizing. You can just move on. And then some things you can do to get more comfortable is practice when the patient's not in front of you and role play with someone you trust.
Many of you may know Dr. Muckle Rothman, and she talks about like at home, like playing with calling, like she talked about calling her husband, changing pronouns at home. So changing his pronouns to she, her pronouns, or changing to they, them pronouns. So practicing on people you're super comfortable with, just playing with pronouns a little bit.
All right, thank you.
All right, we have Alondra now.
Hi, everyone. All right, so pretty much SOGI stands for Sexual Orientation and Gender Identity. So how to access and document. Some general overview. Diana will be doing a rollout official on the workflows pretty soon. And then Leslie and I can be resource MAs in this process in case you have any questions or you just need some guidance. All right. Okay, perfect. Thank you. So pretty much where you can find, like where you can document the gender and pronouns are under the rooming tab, as you can see right here. Just click right here on the gender ID sexuality, or let me see. Got it. Okay. Right here on the storyboard as well, where you can see the little arrows right here. All right, so pretty much ask patient sexual orientation, as you can see right here. It doesn't have much variety. Unfortunately, we are working on that. Dr. Loeb just recently put in a ticket so we can have more variety right here. In case you can find your exact documentation that you want to put on here, just go under sexual orientation, little comment on here, and that's where you can put what you're looking for. Legal information is something that we don't supposed to be messing with. Pretty much you can ask Patricia to help you with that. She's your to-go-to person. All right, so the main three, which are very important, Dr. Loeb and I were discussing, were patient gender identity, patient sex assigned at birth, and patient pronouns.
So, and just, and you can skip if you want the sexual orientation, because as we've kind of talked about, that can be very tender, and we will roll out some official workflows for this, so don't feel pressured to do it, but we just wanted people to get a view for what SOGI looks like.
And also, Leslie and I were talking about it. It's not only that one, is the patient sex assigned at birth. It can be a little bit tricky, to talk to patients about it. Therefore, if you're not too comfortable asking the patient this, just, talk to your provider and have them do it.
And then the second piece of it is generally for providers. Mostly I have this up. I wanted to go through this today just to give everybody in the whole clinic a feel for what is SOGI, and then and what's in there. So again, this is just the second half of it. So it has the sex assigned at birth, the patient pronouns, and then the organ inventory. So the cool thing about this, the reason to do this is that's how this gets there. So this male here is their gender. Their legal sex on this patient is actually female. And then the pronouns are he, him, his. So this goes to the whole entire system. Will then hopefully look at this. And so they go to cardiology and they have the correct pronouns and they have the correct gender. And so if the more we do that, the more we update it, the more people in our clinics. So since we haven't rolled it out yet officially for MAs, it will be coming soon. But just know that as providers, we might want to be paying special attention to making sure that's updated, especially until we get our workflows really flowing for MAs and front desk, because it changes their prescriptions, it changes everything, and that sort of what organ inventory will change their preventive care. It'll change the healthcare maintenance module. So it is a powerful tool in Epic, just to kind of clue everyone into that. All right, and Kylie.
Hi, everyone. I am going to talk to you today about our integrated transgender program and how to refer patients. So just a brief background, our clinic was established September of 2017. We are housed within the endocrinology outpatient clinic on the 6th floor, and we have clinics twice a month on Friday afternoons. And that is when multiple specialties and providers all meet in the endocrinology clinic and see patients together. We have seen 781 patients total from September 2017 to this past December. And 258 of those visits were completely new, unique patients to our program. So the same-day services that are offered in the endocrinology clinic include endocrinology for hormone therapy, primary care. Primary care also does hormone therapy, mental health, OBGYN. It allows for a gender-neutral space for patients to receive their pap smears, things like that, plastic surgery, social work, and we also have a chaplain. Some consulting services. So these would be services that are offered within the system, just not in the endocrinology multidisciplinary clinic that happens twice a month. So urology surgery, so like facial feminization consults, fertility preservation, infectious disease, neurology, and then support groups. Those don't happen there either. And so you might be asking, well, how do we refer patients? So if you would like to refer your patients to the multidisciplinary transgender clinic, then you would simply place a referral to AMC Endocrinology, that's REF22, with the diagnosis code of gender dysphoria, and then specify the reason for the referral in the referral notes so I know. And then patients can also call. A referral isn't required. So they can call or email, and I will get back to them. And then keep in mind too, if you're just wanting to refer your patients to a single specialty such as surgery, then please place that referral to that specific specialty as you normally would, just because we like to save the multidisciplinary clinic for patients who need multiple services in one day. And so you would just give the patient the number to that specialty, and then they could call and schedule the appointment there. It doesn't necessarily need to go through our clinic. But I will say, if you do have a patient who's having difficulty navigating the system or has specific questions on any type of care, I'm more than happy to reach out and have a discussion with them and help direct them into the right place. And then also a link in Epic will be available soon to lead you to our website, which will list specific referral tips and instructions. And so you're probably wondering, well, we don't have a designated person in internal medicine to schedule transgender patients, so who should be asking the SOGI questions? Well, anyone. So the person registering the patient for the first time, so who's ever taking that first call. And so yeah, scheduling the patient, the MA who is rooming the patient, and then the provider. The reason why we're asking so much is because we need to verify this information frequently, because pronouns and names can change throughout someone's transition. So we always want to be respectful and call somebody by their correct name and pronouns.
And then I just want to let everyone know that currently in the resident room, there's a lot of resources up on a board. And then on the GIM Teams page, Allison is building a set of resources. Eventually, this is going to be transferred to, actually, we have a website we're building for the transgender, gender diverse, what did we call ourselves? The University of Colorado Gender Diverse Program.
Yeah.
So, and that is going to link directly to Epic. So we do want to make this as easy as we can. So, you know, in those like Metro Denver resources, you can click and you'll get this whole set of resources. We want to make it as easy as possible. It'll all be physically in paper form in the resident room as well. And just come to me if you have questions. And then again, on Thursday, there will be a talk with nurses and providers on hormone therapy, medical stuff. And then next Tuesday morning, we're doing, actually, Benny is leading us in a talk on trauma-informed care for trans patients and all patients, really. And I left no time for questions. But if you want to stick on, I'll stick around, and the rest of us will stick around. I know that other people probably have to start seeing patients, but we'll stick around if you have questions.
Bye, everyone. Well, from me.